Thank you guys so much. It's really a pleasure to be back with this meeting. I remember participating in Sitges several years ago, and it was just a really incredible experience to hear all the perspectives and to meet people from all over the world, all unified to fight this disease. So again, thank you so much for inviting me. I just want to check a technical thing. So are you guys seeing just the slides here? You're not seeing like all of the, like the presenter view? Is this right, screen sharing?
Yes.
Yeah. Okay, great. Perfect. All right. So, so over the next few minutes, we're going to talk about managing progression of metastatic GIST. And basically, the things that we're going to talk about include really delving into the different types of progression and how they differ in impact of patients. And we'll spend some time talking about KIT resistance mutations, which are really what drive the biology of progressive disease. We'll talk a little bit about some of the newer tools that we can use to identify patients' mutations and kind of speculate on how this might ultimately change the way that we're treating GIST patients. And we'll spend some time looking at specific treatment options for localized progression, as well as touching on drugs that are used for widespread progression. So I always like to start with a case because I think it kind of puts things into perspective. And we'll actually talk about two cases that illustrate the differences between different types of progression in clinical scenarios. So the first one, a 62-year-old lady who initially presented with abdominal pain and weight loss. Her scans showed multiple liver lesions as well as peritoneal implants or disease within the abdominal cavity without a clear primary tumor. And we'll take a look at these scans here in a second. She had a biopsy and the pathology showed spindle cells that were positive for CD117, which is KIT, as well as a protein called DOG1, DOG1, or done in GIST, which sort of sealed the diagnosis for gastrointestinal stromal tumor. And she had mutation testing early on that showed an exon 11 mutation. And so we started her on imatinib 400 milligrams daily, and her scans showed a nice response with some shrinkage and death of the lesions by about 6 months of treatment. And she did well for 2 years. But then she came in and was found to have an enlarging lesion in her liver that was concerning for resistance to imatinib. So here's a picture of her scan. So again, looking at CAT scans, imagine that the patient's lying with their head into the wall behind you, and then the feet are coming towards you and we're chopping them like a loaf of bread. So this is a slice, again, of the liver, which you can see here. And so when we're looking at scans to try to help determine whether or not the disease is progressing, there's a few useful things that we look for. One is looking at density and enhancement. Enhancement means basically the glow with contrast and can be applied to either CAT scans or MRI scans. PET scans can be very helpful. These are scans that use a fluorescent labeled sugar that glows usually bright orange if it's being taken up by an active tumor, as opposed to not glowing if it is a dead tumor. And as we'll talk about a little bit more, size is not always reliable in GIST. Just because a lesion's getting bigger, it does not mean it's getting worse, particularly if it's dropping its glow and its density. So to give you an example, you can see in this liver slice here, there are several lesions that are dark gray that all look about the same. And these are consistent with stable dying lesions or inactive lesions. Whereas here at the base, at the back of the liver, really, you see this more complex area with some white and some darker grays. It's more mottled. And this is the enhancement that we're talking about that's consistent with a progressive lesion. So situation where you have one tumor growing and many other tumors that are sitting there not really changing much. And so we'll contrast this situation with a different patient, 40 years old, presented with GI bleeding, had a big primary mass in the duodenum with multiple liver lesions. Because she was bleeding, she underwent surgery right away. Again, had a biopsy that confirmed the diagnosis of GIST, and her mutation testing showed exon 9. Oh, so this is interesting given our conversation before we started this talk. But we again started her on imatinib 400 milligrams daily for 1 month to try to get her used to treatment. And then we gradually increased to 800 milligrams daily, which has been shown to be more effective for exon 9. And so scans again showed stable disease for about 6 months. However, imaging then showed multiple new PET avid lesions in the liver concerning for progression of disease. And so here's a PET scan, again, same type of imaging, but you can see these bright orange areas that represent the tracer being taken up by active tumors. And so here you can basically see the areas of new disease that are present and glowing that are concerning for resistant disease to imatinib. And so these two cases illustrate really the main two types of progression, limited or widespread progression, and these are treated differently. So if this is our liver with multiple lesions that are active to begin with, the hope is that when you start treatment, these all become stable or necrotic and dead. But what we know is that over time, there are the development of new mutations in the KIT protein that lead to imatinib resistance, and we'll talk about that a bit more. And the idea is that if you have only limited progression, so one lesion that's growing and becoming more resistant, you want to try to target this resistant lesion and keep the imatinib going for the other lesions that is working. So that way you don't burn through your drugs, and you're really just dealing with populations that have developed new mutations and are becoming resistant, as opposed to reinventing the wheel. And this is good for patients who often will have more side effects with some of the newer drugs, and just kind of keeping the tools in your toolbox, slowing things down. If you do have a situation where multiple lesions are progressing, then most often we wind up needing to change therapies. And it's at these points where one needs to think about potentially rechecking mutation testing. And we'll talk about this more, but the idea is that do we know more, and can we better alter our therapies if we know exactly what mutations are driving the growth of disease? And so we'll talk about that in a little bit. So this is not anything new for this group of folks. So this is really looking at GIST genetic mutations, and we know that the vast majority of GIST have c-KIT mutations, about 80%. About 10% will have mutations in PDGFR, and then there's a smattering of other mutations and abnormalities that we're increasingly being able to recognize, with about 30% of the previous wild type GIST falling into the SDH deficient class. And I know that you guys are hearing a talk on wild type GIST, really interesting disease. We're learning more and more about it every day. And so looking at how this plays out, what does it mean? What does it really impact? How does it impact the patient with these mutations? So this is my little picture of a KIT receptor. So KIT is really a protein that acts like an antenna. So it's got multiple pieces. There's the outside part, outside of the cell membrane, which is shown here by these little structures. And this is really where the proteins bind to the receptor and signal activation in a normal situation that gets carried down the stream, activating these other domains of the protein or portions of the protein, and leading to signaling further on downstream in the cell. So it's really a signaling antenna. And all of this activation normally is dependent on ATP, which is an energy molecule that helps to kick off all of this signaling. It's required for that. And so what happens in GIST is that you have mutations in these various parts of the protein, right? And so what happens is those mutations change the structure and lead to the KIT receptor signaling always being turned on, regardless of anything, whether anything is binding to the antenna outside. And so, for example, each of these specific mutations, we know where the structural problems are. So, for example, exon 9 is outside of the cell in the actual antenna piece, whereas exon 11, the more common mutation, it occurs very close to the membrane. And then basically here, we have exon 13 and 14, as well as 17 and 18, which occur downstream. And so it's important to know that imatinib exerts its effects. It blocks signaling really very close to the ATP binding site. And so this is why if you get mistakes that change the structure around the ATP binding site, like exon 13 and 14 mutations, or further downstream, this is why imatinib stops working and you get resistance. And so many people have written beautiful work describing the impact of mutations that occur in a secondary fashion. So if you start here and then a cell evolves an additional mutation further downstream, this is why you get resistance. And you can see here, looking at these secondary mutations, that as you get them, drugs stop working. Even Sutent, which is represented by Su here, is pretty good for 13 and 14, but not so great for 17 and 18. And this has really been the challenge to drug development, is how do we target these more resistant mutations while keeping the majority of the disease that still is exon 11 or exon 9 responding. So we'll come back to that in a little bit, but for local or nodular progression, so presumably this area may have evolved one of these resistance mutations, but everything else is pretty much still remaining sensitive. So the goal, as I mentioned, is to target this lesion and leave the rest of it alone. So keep Gleevec on board, keep the rest of the disease under control, and then come up with something to do for this resistant clone here. So what can we do? So treatment options can include surgical resection. We've had patients who had surgery for a resistant clone, particularly if it was causing a lot of problems like bleeding, and they've done extremely well. You can use radiation therapy. Radiation has not been typically used that often for GIST, simply because most patients tend to have widespread little cells that are away from one particular radiation field. However, in a situation where you're trying to target a relatively small area, this can be very effective. We'll talk in a minute about some of these other things we do. So these are liver-directed therapies, including embolization, ablation, as well as electroporation. And these therapies are really what can make a huge difference for patients. They are outpatient procedures and they're well tolerated. And so it avoids the need for a big recovery after a surgery or needing to hold systemic treatments that are really doing the lion's share of the work, holding the rest of the disease at bay. So ablations and embolizations. So ablations basically are performed by interventional radiologists. And the idea is that the patient is put under sedation. Small needles are placed under X-ray guidance into the liver through the skin and into the tumor itself. And these needles basically act as a conduit where you can transmit various things. It could be heat, it can be ice, it could be microwave energy, or even electricity. And there's differences across these, but this is the basic idea for an ablation. And so here's another picture I pulled out from this paper on the internet. This is the liver that we've been looking at, similar cut, and this is the tumor right here. And these bright white lines are the needles actually being placed inside of the tumor. And what happens, this is a cryoablation session or freezing, and they actually build an ice ball. You can see this round area around the tumor, which is kind of in the middle here. And that ice ball leads to local tissue death. That tumor is neutralized in a very effective and very controllable way, actually. They can control very precisely how far the ice ball goes in order to neutralize that lesion. So very effective, very focal, and relatively well tolerated. The other option is embolization. So in embolization, instead of going directly into the tissue, they go into the blood vessels that feed the tumors. And so here's a picture that you guys may have seen previously. So again, here's our liver, here's our tumor. This is an angiogram where they've injected contrast into the blood vessels, and you can follow them along here. And basically this blush right here is where the tumor is being fed by this mesh of little tiny blood vessels that provide nutrients. So in embolization, they would go into these vessels and then fire something to block the blood flow. So that can be a material like a polymer that just literally blocks the blood flow and kills off what's beyond that. They can fire chemotherapy beads. They can fire radioactive particles, like some things like Y90. So it's, again, a very focal way to deliver toxic things or block the blood flow to those tumors and kill them off. You can see here, this is the same patient from case 1 where she had this big lesion here at the back of the liver, and after embolization, the vast majority of that active lesion has turned dark, similar to her other dead or dying lesions. And sometimes we do repeat these procedures. You can do it more than once, particularly if there's a little bit of leftover tissue behind, like you can see here, and patients tend to tolerate that really well. So these therapies are increasingly being used for patients that have one problem child lesion that needs to be taken care of. So then we're talking about widespread progression. So there's a few little clinical tips that I like to remind folks about whenever you're dealing with metastatic disease and you're trying to figure out if you need to change therapy. So number one, you always want to confirm the disease is actually active. So this is what we touched on earlier, using PET scans or contrast enhanced CAT scans, because we're looking for pseudoprogression. And we'll look at a couple of examples of this where you think the disease is getting worse based on the scan, but in reality, it's actually responding. The other thing is that patients who recur or develop metastatic disease after stopping adjuvant imatinib, almost always those tumors retain their sensitivity. So if they started out exon 11 and you stop the adjuvant imatinib and then it comes back, most of the time you've removed the main pressure for that disease, and you don't need to assume that that disease is going to be resistant just because it didn't die with imatinib. We know that imatinib kills a lot of GIST cells, but it doesn't kill all of them, and it tends to put the tumor cells to sleep. And if you stop it, many, many times you'll have residual hiding cells waking back up again. So I always at least try to restart imatinib in that setting rather than changing therapy unless there's some clear evidence that the tumor is completely different, which we usually don't see. We talked about this as well. So if they're progressing on imatinib at 400, I always try to attempt increasing the dose if they can, because we know we will rescue additional patients. The doses can be challenging from a side effect perspective. I've had better luck splitting the dose, so this is a good trick for our folks who are struggling with these higher doses. But generally, people will tolerate imatinib at higher doses better than some of the drugs that come afterwards, like Sunitinib or Regorafenib. So I always try to use up my imatinib before I go there. Again, for recurrence and progression that is only in a few sites of disease, I try to be aggressive. So once we get a response, we get the disease controlled. For patients who don't have too much disease, I think about surgery or ablation, especially in that first line, just because, again, if we can reset the clock, many patients will do very, very well for a longer period of time. And then finally, if you are going to biopsy to get additional mutation data, make sure you get a true progressing lesion in an area of the tumor that's progressing and not stable lesions to increase your information. So here's the pseudoprogression idea. This is a couple of scans, a CAT scan for baseline, and then this is 3 months later. So if you look here, you can see these little dark spots that we could see pretty well at baseline. And then looking 3 months later, oh my gosh, there's a bunch of new spots that we couldn't see before. And here at the dome of the liver, we don't see anything. And then we've got new spots here. So this looks bad. This looks like, oh my gosh, we've got new tumors that we're seeing. But you know that you see that all of these look pretty dark. They look pretty dead. And so if you get a PET scan, you can confirm that even though this is the same area where we were seeing those new spots, they are not glowing. They are indeed dead. And so something that the illustrious Dr. Trent taught me many times is that just tumors that are untreated can be very, very close to the same color as the background liver. And so when you start, you might not be able to see some of those tumors. And then when you treat them, they get darker and they die and you can see them for the first time. So it can look like a new lesion when in reality, you're just treating tiny spots that were already there that you just couldn't see at baseline. And so that's pretty consistent with what's happening here. So we would, if we didn't get the PET scan, we would have changed treatment. We might have increased dosing. And in reality, we're doing just fine. Things are responding nicely and the patient should continue on therapy. So if you do confirm progression, however, what is our current schema? So at least in the United States, and I think elsewhere as well, we now have drugs for first line, second line, third line, and fourth line. And so the standard procedure would be to start with imatinib. This is for assuming routine KIT mutant GIST. Progression-free survival is about 2 years, but we all know that there are patients that have done well on imatinib for much, 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 much longer than 2 years, and also patients who progress faster. So again, first line, still imatinib. There was a clinical trial several years ago looking at the first line against masitinib, and that seems to have fallen away. I'd be interested if anyone knows of the status of this study or if there's any plans to look at that data, because as far as I know, we never got any information about that. But otherwise, imatinib is number one. Sunitinib is approved for second line treatment, and the progression-free survival is about 7 months plus or minus on sunitinib. And as you know, there is a clinical trial going on right now comparing Sunitinib versus Ripretinib, one of our newer drugs, in the second-line setting. So time will tell whether or not Ripretinib is the winner over Sunitinib for second line. For third line, Regorafenib is number 3 with a progression-free survival of 5 months. And we recently got the results of a clinical trial that compared, again, one of our newer drugs, Avapritinib, to Regorafenib. And unfortunately, Rego was still the winner in this study. So that remains the third line player. And then recently in the United States, we approved Ripretinib for fourth line GIST, again, progression-free survival of about 6 months. And so basically you have the option, and the standard of care would be to follow this progression, right? So you have a patient who is progressing, number 1, start with imatinib, change to Sunitinib, Regorafenib, Ripretinib. And that's, that is an approach that would be pretty standard, at least in the United States. You always, of course, want to get the mutation data to begin with, because you want to rule out things like the resistance mutation, D842V. And we do now have an approval for Avapritinib for this particular mutation. So you certainly don't want to put those patients through this if we have a drug that is designed specifically for their mutation. Well, that's great. So what about after that? So we've had patients that have progressed on 4 drugs. There are many other targeted kinase or tyrosine kinase inhibitors that are out there. So now we have multiple different options. How do we choose among these drugs, many of which are not approved, for our patients? And I think this is where we need to do the most work. So we need to look at these different drugs and understand how they work, who they help. And the only way we're going to do this is through more clinical trials. Additionally, there's other strategies to treat GIST, including immune therapy, which I hope that somebody else is talking about during this conference. It's a really interesting area, as well as combinations, so to other targets and things that we can do. So understanding this is really, I think, the direction we need to go. So how can we choose which drug we should be treating patients with? Well, one option would be to look at that mutation data. So there are, as I mentioned, there are different mutations that come from resistance. And so is it really helpful to understand this for patients? There's 2 ways you can do this. You can put the patients through another tumor biopsy, but you have to pick usually 1 lesion, and the needle that we use is about 1 centimeter or so. So it's a very small sample of what you're actually looking at in the patient, who may have a dozen or 2 dozen tumors, just a teeny tiny little piece, and hoping that represents the rest of the disease. The other cool technique that Dr. Trent and others have published on recently is this use of circulating tumor DNA. So circulating tumor DNA involves taking a blood sample and performing genetic sequencing on DNA that's floating around. What happens is tumors can shed DNA into the bloodstream, and in theory, this would be a way where all of the different tumors that are in the patient could be theoretically dumping DNA into the blood, and may give you kind of a global look at what the mutations are in that particular patient. Now, this sounds great, but the reality of this is that we're not quite there yet with the technology, in my opinion. So this paper, again, from Dr. Trent's group at University of Miami, looked at patients that had tumor biopsies and compared them to circulating tumor DNA samples, and looked to see how often they could pick up mutations that way. And so at the end of the day, most patients, if they had these big standard mutations like exon 11 and exon 9, you were going to see. But you can see that the tumor biopsy was picking it up more often compared to the circulating tumor DNA. And so it came down to a detection rate overall in this set of patients, about 40 patients, was about 56%. So that means that even though the patients had tumors and they had disease, circulating tumor DNA was negative or not picking up the mutation almost half the time. And it turns out that the patients where this was happening, where the circulating tumor DNA was missing the mutation, is when you have very low burden of disease, so very few tumors or small tumors, and the tumors were actually responding to treatment. If you reserved and only looked at patients that had a whole bunch of tumors or large tumors and they were progressing on their current therapy, at least in this set, the technology looked a little bit more sensitive. You were more likely to get something that was actually helpful, or at least you were actually able to catch a mutation. So this looks great. However, then the question is, well, what do you do with that information? Can we use it to guide treatment? So this is a chart of many of these drugs that we've been talking about. And this is sort of pulling together data from small numbers of patients, and it's all from clinical trials. So this is still a work in progress, and we're building this data set. But the take-home point is that different drugs are going to work for different mutations in different ways. So we know, for example, Sunitinib does work against exon 13 and 14 resistance, but not for 17 and 18. And similarly, we have these panels for many of these other drugs. Ripretinib is supposed to work pretty well for all of these. It's been designed to do so. However, we know that patients become resistant to ripretinib as well. So in theory, what I'd love to get to is where we have a test that's sufficiently sensitive and we can say, okay, our patient has exon 17 and they have exon 13, so I need to find a drug or put two drugs together that will provide coverage across those different mutations. And I think we can get there, but we still have a ways to go. The other factors that impact our choice of drugs include side effect profiles. And so again, this is just a summary. Most of you know this. Looking at the differences between KIT selective drugs, so imatinib, especially at higher doses, and our new player avapritinib, compared to the other TKIs that are a little bit broader. They hit other targets besides KIT, including vascular growth factor. And so just to remind you, one of the big issues with avapritinib is this cognitive dysfunction. So patients have trouble thinking. This is the chemo brain, but taken way further, where there's actual measurable abnormalities in memory and other function. So this, to me, this was always the biggest challenge with avapritinib. And so again, we have to usually dose reduce patients pretty early, and whether or not that impacts the activity remains to be seen. I'm convinced that it definitely does for KIT mutant GIST, but hopefully for PDGFR, D842V mutant GIST, even with dose reductions, the drug is so good for that kinase, for that protein, that's not going to impact patients too terribly much down the road. Our other drugs, again, pretty different side effects: high blood pressure, hand-foot syndrome, risks of bleeding and blood clots. And then with our new player ripretinib, it's just important to remember that patients can have loss of their hair, which is pretty unusual. Our patients on Gleevec complain of hair thinning and some other issues, but in general, we don't frankly have hair loss. And then, of course, there's also the risk of skin cancers in ripretinib, which is new compared to other drugs. So just finishing up here, I realize I'm running a little long. So to take home, it's important when you're dealing with progression of disease to use imaging to confirm the extent. Local modalities can be very effective to go after resistant clones and allow you to keep your systemic therapies handy. Mutation testing at diagnosis is definitely critical, and I think ultimately we're going to be using it more and more in the setting of progression to help guide subsequent treatments, but we're not quite there yet. We have more work to do. And then finally, I think it's amazing how many drugs have come out since even I've been in the sarcoma world. We're seeing custom designed therapies that are really offering hope for patients with resistant GIST, and the numbers are just getting better and better. Of course, the other thing we need to continue to work on is access. So I've shown you some great therapies that may not be available off-label or through some of our other countries. And so we need to continue to work to make sure that patients have access to the latest and greatest treatments. So thank you so much. And again, I'm happy to take questions.
Thank you.